We originally anticipated or planned for this seminar maybe a couple of months ago, and things have moved on in so many directions, including in the last few days. But basically, the issue here about smoking and COVID is what is the chance that somebody will acquire the infection? And that's a sort of a black box that can be input by a number of things. And then there is this thing called luck and additional risk factors factored in. And then you've got critically the progression to severe COVID disease. And in fact, it's not a disease that we'd have to do much about if it wasn't that some people got very sick. Because the majority of people have a mild illness. It's the sharp end of people who are older, and we'll come back to that, and sort of comorbidities that are important. Otherwise, you just let it rage quickly through the community, and all would be well after a period of time. I mean, these are essentially the questions that have come up in debate and some limited publications, is whether smoking helps or hinders the acquisition of infection. Does nicotine help or hinder acquisition of infection? And does smoking or nicotine, sorry about, I've duplicated the last one, does smoking or nicotine help or hinder the progression of SARS infection to clinical disease, and in particular severe COPD, severe COVID, that causes hospital admission, intensive care, and sadly death amongst some of the people infected. So, I mean, the history here was that the initial studies from China reported that there were very low rates of smoking amongst the hospitalised patients, in particular, and the critically ill people. And it was from there that arguments developed that smoking may have been highly protective. There are lots of problems with that interpretation, not the least is that there were still more male cases than female cases. And if smoking was really so protective, you'd see a flip. So you'd end up with more COVID cases in women and men, given that women were more likely to be elderly or they formed a larger proportion of the older population, well and truly understood to be at risk at that time. And on the other hand, and I'll come back to this, that having smoking-related disease clearly increases severity, and I'll talk about COPD separately. So, related to this, developed, because of the philosophy that smoking surely can't be good for you, or maybe it's a nicotine thing, and from this developed the nicotine hypothesis. Essentially built around this construct that a portal of entry for SARS, the covirus or coronavirus, is the acetylcholine, the angiotensin converting enzyme to receptor, and nicotine can alter the expression of that receptor. There's conflicting data in vivo and in cells, but the alpha-7 nicotinic acetylcholine receptor can upregulate or alter the expression of that particular enzyme receptor, but the enzyme receptor happens to be one of the portals for entry for coronavirus into the respiratory system. So here was the argument: nicotine could be protective. That might explain why there were fewer cases in smokers, if that were true, and even raised the postulate amongst some of the usual suspects. Well, maybe we should encourage exogenous nicotine to get this effect and protect people, but this was never supported by data. But in a very fluid environment with lots of journals, some of high quality and some of lesser quality, There are a raft of publications. The position of WHO as of late May was that there are currently no peer-reviewed studies that have actually evaluated the risk of infection amongst smokers versus the rest of the population. So I'm sorry that a lot of the stuff I'm going to give you is mud, not clear, but that's the way the world works. But the WHO says the research question needs well-designed population-based studies. Problem is that the healthcare resources are so directed towards acute care. Actually doing those sort of research studies is naturally a lesser priority. We've got capacity to do it in this country, but at the moment, save out of Melbourne, we don't have many cases to prevent. So yeah, it's this thing where, you know, the healthcare systems in Europe, in the UK, in the States, and across many other parts of the world have been incredibly taxed by this epidemic, as you know. So then you come on to other sorts of evidence. There's a really interesting thing called the COVID symptom tracker. So I'll just say quickly that nicotine otherwise sourced, there's no data and lots of discussion. Let me just, okay, so this is basically a study portal or a study that's conducted mainly in the UK, where you can download an app and report regularly on symptoms, in addition to having some baseline demographic data. At the time of the publication I'm going to refer to, there were 2.4 million users, and now it's nearly 4 million people tracking their symptoms in the UK. Maybe that's what social isolation, physical distancing does to you. You've got nothing to do in England apart from doing this, but nonetheless, it's an interesting experiment. So I've got some data from that, which is data mature in late April. And I caution to say this is from a preprint, but it's from very good people at the National Heart and Lung Institute, one of my former homes, from King's College London, and Zoe Global are the app manufacturers. So they had, at that point, 2.4 million participants with a mean age of 44. Majority female with a smoking prevalence of 11%, which is a little less than the UK population, but probably pretty close to a population with a mean age of 44 over there. 35% of them over the period of time reported being unwell and ended one or more symptoms. Amongst those who identified at entry as being a current smoker, they were more likely to develop symptoms with an odds ratio of 1.14, and further, as you go to more symptoms, 5 or 10 symptoms, the odds ratio increased. Interestingly, they did a sub-study where they looked at fat sample for ACE2 expression, and it was reduced. So it's a vexed issue about the in vivo, in vitro ACE2 argument. I think that's basically a distraction. All right, now there was a subpopulation of those who were tested. So 1.1% of the 2.4 million app users with data available. And there was a bit of a bias here because the tested population were more likely to be healthcare workers, and 31% of those who tested positive were healthcare workers. That probably reflects testing rates rather than infection at work, but it's another complicated story. Smoking rates amongst those who were tested were lower, and smoking rates were lower in those who tested positive compared to those testing negative. So, however, symptom burden was higher in smokers who tested positive compared to non-smokers who tested positive. So this paradox of not a clear increase in infection acquisition, but a clear increase in symptoms. Current smokers who tested positive had a higher risk of attending hospital, and that was doubled. And this sort of builds into a theme of equivocal evidence for infection, but pretty strong evidence for progression. And even if you looked at those who had, if you took out subjects who had reported comorbidities, the effect was still there amongst the non-comorbid population. So what about further evidence that smoking helps or hinders progression of infection to clinical disease and severe COVID? Well, the CDC lists these things as having the strongest and most consistent evidence for severe disease. Severe heart disease, whether that's vascular or congenital, chronic kidney disease, and unfortunately at our hospital we've had two. We had one infected outpatient dialysis patient who transferred it before the diagnosis was made to another, and unfortunately they both died. We were lucky enough to stop it spreading through the rest of the outpatient dialysis population with a lot of really hard work. COPD, being overweight with a BMI above 30, sickle cell disease, not a big issue in our population. Recent solid organ transplant, that's why kidney and liver transplant programs were suspended, and type 2 diabetes. Age is a risk factor, but it wasn't specifically factored into the CDC. It's not on the CDC's list, but there is very strong and consistent evidence that the older you are, the sicker you get. Mixed evidence for asthma, hypertension, cerebrovascular disease, pregnancy, and they list smoking and immunosuppression, and blood group A. All those people anxiously looking at their known blood status. Now, I lived for 60 years with blood group O, and then 2 years ago I had a stem cell bone marrow transplant from this beautiful woman, who's my older sister Julie, and she is blood group A. So I've gone from having being a male with blood group O to a female with blood group A. It makes me a great criminal. I could just leave blood at the scene of the crime and they're looking for a woman with blood group O where the records indicate differently for me. But anyway, but it's interesting that being blood group A incurs a 50% incremental risk for progression to severe disease through a mechanism which is uncertain. It's probably that there is another gene close to the blood group genes that influences the course of the disease. After all, these are just antigens that sit on your blood cells. But this is a gene association. I should clarify. It's a gene association with being blood group A rather than just being blood group A. So maybe Julie hasn't done me quite so much harm as I'd like to tell her. All right, lots of different analysis. This is one from Stan Glantz, looking at smoking and progression. And they find that the progression to severe disease with this meta-analysis, including published studies, English language and Chinese language publications, the odds ratio of smokers versus non-smokers progressing to severe disease is about 2. So we'll pass through that one. Sorry. The question is, does nicotine help or hinder progression to severe disease? No data. So basically, the WHO position at the end of May was that smoking is associated with increased severity of disease and death in hospitalised COVID patients, and no evidence to quantify the risk to smokers of hospitalisation or of infection, and that population studies are needed to address the latter questions. And of course, issue du jour, are vapors more susceptible to COVID-19? Again, there's a paucity of information. This is available on the net, again, as a preprint, not peer-reviewed. And they looked at the known vaping rates from US states, compared them state by state, and the vaping was defined as every day or some day based on 2018 data. And those states that had higher vaping rates had reported more COVID cases and more COVID deaths. And, you know, there was an argument that this would be concordant with a fairly consistent finding now of excess pneumonia cases in those studies that looked at electronic cigarettes versus NRT in smoking cessation trials. Now, I wouldn't get too excited about this, I'll leave it out there with you, because it could be that mechanisms other than susceptibility are at play, because vaping from first principles is doing everything that we're trying not to do in hospital in terms of spreading bugs by droplet and aerosols, and particularly if you have small, poorly ventilated smoking / vaping areas. And also, as you see just from watching the news, the vaping or the COVID epidemic is not mature in the US. And doing a study like this comparing vaping rates by state with eventual cases and eventual deaths will be informative, but it may be that there's biases introduced just in terms of the states where the virus came first versus ones that are now experiencing a much more substantial number of cases. So clear or mud, I don't want to finish on that, but I can stop sharing. So that's just exactly where it is, and I'm happy to answer questions. The data shouldn't be stretched beyond what they tell us, and the studies are limited and the conclusions are cautious. But happy to answer any questions, Louise.
Okay, thanks, Matthew. I've opened my chat box. If anyone has any questions, if they could type them into the chat box. A couple of minutes. Questions as yet? So I'll ask a question then. Just hold on, I'll go back. So with the evidence from that study with the vaping, I know that it's still sort of not clear because we don't have enough data yet. But was that study from particular states, or was it looking at vaping in only certain areas in the US? Or
no, it was a state-by-state comparison.
Yeah.
But you know, I include it because it's the only data that are available.
Yeah.
And the issue about vaping is a more general one, and certainly in countries where coronavirus, you know, the virus is common.
Yeah.
The risk of dissemination from asymptomatic or minimally symptomatic people who vape, it has to be considered significant. You know, in the Australian context, where, except for out of Melbourne, the virus is extremely rare, it doesn't even rate a mention.
Right.
And as I say, those data would come from an immature phase of the epidemic.
Yeah.
If you compare states by vaping rates and eventually COVID, you need to be doing it in 6 to 12 months' time.
Yeah.
So I don't think that we should be altering any position on e-cigarettes and vaping based on that. Just
No.
it's there for completeness, and there are
Yeah.
no other data. But certainly, what was put up at one point was that we need to get more nicotine into these people,
Yeah.
because more nicotine will help them and they won't progress to disease. That was always a nonsense argument.
Yeah.
And so it's proven.
Yeah. Okay, we've got a question here from Kirsty. She's could you return to the slide on factors bad for progression, including serious heart disease?
Yeah. Yep. Okay. Happy to. Yep. So Kirsty, what's the question? Oh.
Yeah. She hasn't written a question. She's asked to
okay.
go back to that slide.
So in the end, I settled on the way the CDC had put it, which is a bit different from the Australian one. But the CDC update only last week, you know, on the weekend really. So serious heart disease means ischemic heart disease, heart failure, or congenital heart disease. Having a COPD and smoking is an incremental risk above having COPD. The COPD risk is about fourfold for progression to severe disease. So, a particular question from that, Kirsty? And then you come to the second level of where the evidence is a bit more mixed.
Yeah. Is there anything around that? She doesn't have a specific question. She just wanted to look at that slide. But
okay.
Can I just ask on that next slide, the pregnancy? Is there any information around that?
Okay, so this is not. There's equivocal concerns about that. This is not like pandemic influenza, which was a severe disease in pregnant women and embryopathic. That is bad for mum, bad for baby. This is not the same because it's generally not associated with really high fever, like acute phase of influenza, and high fevers are bad for babies. So it's not of that nature. And there are some reassuring studies, and some not. You know, and this is why they've got mixed evidence. But obviously, you know, if you're in a country where there's lots of cases, some women who are pregnant will get infected, and it's not a good thing to be in intensive care if you're pregnant, either for the woman or for the developing baby. So but it's not. We're not as a routine, for example, removing pregnant healthcare workers from the frontline workforce. There doesn't seem to be an excess of miscarriages in the first trimester, but you know, this is an evolving thing. You know, in March we didn't have any evidence. We had a little bit of evidence from late trimester infections, but it was very hard to know first and second trimester stuff. So it doesn't, you know, it's just a very hard thing to characterise. But it's not the risk that it's not the risk. We haven't made the changes in healthcare worker allocation or like we did with swine flu in 2009.
Yeah. Okay. We've got a question from Renee Batoon. She's asked, is there any comment on the immunological effects of nicotine on nicotine receptors regarding the cytokine storm reaction?
Renee, there's a lot of comments, but no knowledge would be I don't mean to be critical of other people. The cytokine storm is not easy to manage. steroids actually seem to be protective. We've used lots of, there have been specific interleukin receptor antagonists. Tocilizumab is one. We've used that. We've used it in 3 patients. One survived, but is a respiratory cripple. The other 2 were the dialysis patients, and they did not survive. So why older people are particularly vulnerable to this illness and to cytokine storm. There's so much which is fascinating about this disease. Why does thrombosis occur? One of the 2 dialysis patients died after they clotted all their vascular access, and then they could not be dialysed anymore. The other had a massive intracerebral hemorrhage. So that's how we lost our 2 dialysis patients. But this issue of a prothrombotic condition associated with cytokines and why that should occur with age is a fascinating thing. But to say that nicotine can manipulate it is not, well, it's a spectacular stretch.
Okay. Any other questions? Okay, one from Nancy Westcott. Have you got a wrap-up or summary statement takeaway for me? Is there good evidence for increased severity and progression, but not so good evidence for susceptibility?
Oh, look, I think that's a fair summary. COVID's probably increased interest in smoking cessation. There's a couple of bits of information about, actually information gathering. And as I said at the outset, did an ABC interview. Not smoking at a time when the healthcare resources are taxed by COVID is a brilliant idea, because the last thing you want to do is to become a potential consumer of the healthcare system at a time where it's struggling to provide for other things. Leaving aside COVID, it's never a bad idea to stop smoking. And I think that's the most simple public message. You can protect the healthcare system by not being a potential consumer, and also protect yourself. So that's a very good. But I think Nancy, the message that the evidence for getting the virus, if you're a smoker, is equivocal, or if you believe the symptom tracker, we don't know, because the symptom tracker doesn't consistently tell you whether people are getting infected. I think the evidence is equivocal, but you'll get more symptoms and more likely to progress to hospitalisation and severe disease if you are a smoker at the time that you get infected. And I think that's a reasonable summary of where we are at the moment. And whatever you do, don't smoke.
So should smoking be one of the, should we get better at identifying smokers?
Oh yeah, this was a problem. Yeah, this was a problem in the early Chinese studies, from which too many conclusions were drawn, and that is they had really poor smoking ascertainment and grouping. So some of them grouped ex-smokers with current smokers. Some of them grouped never smokers with status not ascertained. And really then the meta-analyses were done of these studies, and if you meta-analyse rubbish, you can only expect to get rubbish. But the data, to credit to the researchers, were coming from areas where the healthcare system was incredibly taxed, suddenly and explosively, and no one knew at all what to do with anyone. So you can't be critical, but you can't be critical of people who put the data out there to the best of their ability. But you can be very cautious about drawing definitive conclusions.
Yeah. Nancy's got an additional question. She says, also, in view of your previous comments regarding clotting, would it be fair to say that those who have susceptibility to clotting will be a more vulnerable population?
Conceptually, yes. But it's hard to test in that particular population. But aggressive anticoagulation is one of the suggested strategies in intensive care. So yeah, if you have a prothrombotic condition, from first principles, you wouldn't want to get this.
Yeah. Okay. Any other questions? Last chance. Oh, a thank you. Yeah, just give another minute or so. Yeah, it doesn't, I'll just check on the other Q&A. No, there's no more questions there. It doesn't look like there's any more
Okay.
questions.
I just didn't want to dress this up to be something dramatic and, you
Yeah,
know, yet another, you know, incredibly important reason not to smoke. But, you know, it's likely that most states will face outbreaks like Victoria's facing at the moment. I haven't seen today's update. I suspect it'll be near 100. And it's very timely that people in this country think about becoming a non-smoker as soon as possible.
yeah. Nancy's also asked, are you happy to share your presentation?
Yeah, absolutely. I'll just get organised and probably take Julie's photo out, much as I love her. She's not really a bogan,
Yeah.
but it's her fault. She posed for the photo on Christmas Day, I think it was. Yeah, so I might have to take some of the photos out because they're not not because I'm embarrassed about my family. I love them all, but just it'll reduce the file size. Okay.
Yeah. Okay, well, you can
Brilliant.
send that via Liz and then she can send it out. So yeah, thank you so much for doing that presentation
Great pleasure.
today. Yeah,
Brilliant.
that's really great.
You all take care.
All right, thank you.